Welcome to the Medisun podcast. Today we have a great guest, Dr. Roger Seheult. Roger is quadruple board certified in pulmonology, intensive care, sleep medicine, internal medicine. He's also the co-founder of MedCram, which has over 1.6 million subscribers at this point. It's a great resource for whether you're a physician, a med student, or just a layperson like myself. There's a lot of great information on there to learn from and teach the public. So Roger, thank you so much for coming on.
Thank you so much for having me.
I'd love to just jump into a brief background on yourself, how you got into the world of medicine, and
Oh,
eventually starting something like MedCram.
wow, that's a good story. So I um, moved to Southern California when I was 8, to a place called Loma Linda. Loma Linda, California is a small little town. It's a sleepy little town, at least when I moved there back in the 80s. But it had a large medical center, tertiary care medical center, and a medical school and a dental school. Moved there because my dad wanted to go to dental school. So I mean, I just grew up in the kind of the shadow of the medical community, started to meet people, have friends, and they were all doctors and dentists and stuff. And I had no idea that that's who they were because they were just cool people, right? But then as I started to get older and tried to think about what I wanted to do, then went off to college locally at University of California, Riverside in Southern California. Met my wife, who knew what she wanted to be since the day she was born. And I met all these great people and friends that were just really driven to be physicians and people in healthcare. And I was kind of this sort of drifter that just liked chemistry and decided to do chemistry and majored in chemistry. And then I added biology because at some point their drive sort of wore off on me. And I decided that I was going to go into medicine and got into Loma Linda University School of Medicine, and never looked back after that. It was all a matter of really who I was with. I was very influenced by people that were around me. My girlfriend at the time, who was later my wife, went off to a different medical school. She went up to UCLA, and so we had a long distance relationship. But then after I graduated, she came back. We both did residencies together. She was about a year ahead of me because of her program that she was in. And we both did internal medicine. I eventually decided to do a fellowship and subspecialty training in critical care medicine and pulmonary. And then finally added sleep medicine to that repertoire and kind of stayed local. I joined a private medical group in the area, but still taught at Loma Linda and UCR, both of my alma maters, and have been active in the community. When I was there, there was a student that came out, the PA school, a physician assistant school at Loma Linda, would send students out to our rotation. And back in 2012, Kyle Allred, who was a PA student at the time, came. He was on my rotation. I guess he was impressed with my teaching and the fact that I just didn't use like PowerPoint slides, but actually explained what we were doing, and had an idea to start a YouTube channel. I remember the day he approached me with this. He said, Dr. Seheult, people don't study in med school and PA school the way that you used to do it. You used to go to the library and check out articles and open up Harrison's. And he was right. We didn't have we had the internet, we had Yahoo, we had these things, but there wasn't so much content on there that you could actually use it to study, and not like there is now. And so by the time they came around in early 2010s, there was a lot more stuff. People were looking on YouTube to study. If they had a question about something, they would find the shortest video on YouTube. So he saw a real need there, and Kyle came up with this idea of starting sort of like a Khan Academy, but for medicine, and that's what we did. We started that. I named it MedCram. I might have named it something different now because it was more for education. And I still remember our first video that we produced back in 2012. It was on acid base and interpreting blood gases, which is really complicated for people who don't know, and it's even confusing for people who are in healthcare. So we tried to educate, make it very simple, have a step-by-step process, and from there we just took off. And by the time we hit 2020, so 8 years later, we had a website, we were offering continuing medical education. We were getting lots of providers, not only students now, but also healthcare providers that were interested in getting continuing medical education. And we were up to about 400,000 subscribers on our YouTube channel by that point. And then one fateful night in January, there was this virus in the news over in China that wasn't just going away. Like there was something wrong with it. And I had done videos before on Zika virus and other things that would pop up in the news just to be, topical. And my wife said to me one night, she said, "Hey, there's that virus over there. You probably should do a video on that." And so, I think it was a Sunday afternoon, and I dropped the video, the very first video in our COVID-19 series, where we sort of just reviewed what a virus does, how it works, how it takes over the cell, and some things about what was going on. And usually I get about 3,000 views on a video. And the next day I woke up and watched it, and it exploded. And in the first 24 hours, there was 300,000 views on
Wow.
that. And then I knew at that point that there was a huge need, that people were very interested in this topic. And as a science educator that was already in the field, it was my duty, I felt, to bring the best and the best explanations of exactly what was going on, what we knew and what we didn't know. And that sent me down a path that, quite frankly, nobody was expecting.
Hmm. And I love your education style on MedCram. It's almost like, even with like research papers, it's like you're learning with me as you're teaching about it, but it's your curiosity really shines through. How has making these videos on MedCram helped you as a physician?
Yeah, it's helped me as a physician in the fact that it's really opened my mind to all sorts of possibilities. Like most of the time as a clinician, I mean, for those who don't understand or don't know what a clinician has to do, they have to be the master of their understanding. Like, especially if you're a specialist, like you need to know what's going on because people are referring people to you when they can't figure it out. So you've got to be that backstop. And so not only do you have to be ready to deal with difficult cases, patients who are frustrated with the fact that things aren't getting better, you also kind of have to know where to search for things that when you don't know, right? And so in my situation, I'm constantly learning, constantly updating. I have 4 board certifications, and every 10 years I have to recertify in those fields, which means I have to either take, a big examination that I've got to pass, or I have to do, longitudinal learning with that. So, and these are very broad topics, like internal medicine. All of internal medicine is basically all of medicine minus surgery
Hmm.
and obstetrics. And so it's huge. Then there's pulmonary diseases, everything that has to do with the lung. Then there's critical care. Basically, when you go into the hospital and you are critically ill, you got to know how to take care of that patient. And that goes anywhere from, labor and delivery, critical care issues to end of life, septic shock issues. And then there's the whole idea of sleep medicine, which is literally what we're doing a third of our life. And you've got to be an expert in all of those fields. So when you it's almost impossible to keep up with all of the advances. And so what you have to be able to do is you have to be a lifelong learner to be able to figure out what's going on in these fields. And I think the biggest mistake that people can make in the field of medicine is when something is presented to them as new data, is for them to exclude it simply because you've never heard of it before or it's never been presented to you before. I think one of the biggest mistakes that healthcare providers makes is this understanding that they have a full grasp of the knowledge in their field because technology now is moving so quickly that it's really hard to get a full grasp in your field. And I run into this a lot. Sometimes I'll see things that people will talk about and I say, you sure I've never heard of that before? And then you look up and sure enough, there's the studies that actually show it. So how has this changed me? It's really opened my eyes to the denominator in my knowledge. Like how much I know is the numerator, how much there is to know is the denominator. And the denominator is much bigger than I think we all perceive.
That's a great answer, and I think that curiosity is something that's so essential, especially for someone practicing medicine. I know you can get really caught up, and I mean, you got a lot going on. It's hard to balance that with also staying up to date on the new research. And circadian biology is something that I know you're very interested in. I'm very interested in, and I kind of imagine it for you. It was refreshing because it kind of encompasses all of these specialties that you work in, and it's kind of above everything else. What has it been like learning about the nuances of circadian biology, and I mean, with all the new research coming out, what has that experience been like for you?
It's been incredible. It seems to reinforce over and over again. The more we get into circadian biology, and the more I start to realize that we are different people at different times of the day.
Mm.
And things that may work one particular way on average may not work particularly at a particular hour. Such to the fact that I really believe that, and I'm hearing this, that many pharmacological studies on drugs, medications really need to be relooked at because of this issue of the time of day that they were performed. Like if you didn't control for the time of day when a certain thing was given, you may have a lot of confounders there about what time of day this was and what the effect was. We now know, for instance, for many medications, that the effect is different if you give a medicine at 8 o'clock in the morning versus 8 o'clock at night.
Hmm.
And the side effects of those medications may be different at 8 o'clock in the morning than at 8 o'clock at night. And so something that has really intrigued me, and with a number of studies that have recently come out, that you can actually improve somebody's health dramatically, dramatically with just the timing of what it is that they do. So, not changing what they eat, not to say that that can't make a difference, not changing the amount that they eat, okay? Not to say that that can't make a difference, but simply changing when somebody eats, which ostensibly would have no impact on their bottom line financially, right?
Hmm.
So we're talking about zero cost, just simply understanding the time at when things should be done. And the impact that that has is really quite mind-blowing. So yeah, circadian biology is not this sort of thing on the back burner. It's front and center, and I believe it's one of the pathways to to great health.
I agree, and I think online there's a bit of an echo chamber in the circadian biology space. Like you think that everyone knows this stuff, but then you go over to the couple doors down, and no one really they have
Yeah,
no idea what you're talking about.
right.
How important is it to educate patients on their circadian health?
Oh, it's tremendous. Obviously, as a sleep physician, this is what we do every day. I give them I give them sleep diaries so they can fill in exactly, graphically. So
Hmm.
there's like 14 rows of lines, and each column is an hour of the day, and they're blackening in, the hours that they slept. So when they bring it in, I can see a 2 week summary of their sleep, and I can tell immediately, are you advanced? Is your circadian rhythm advanced? Is it delayed? Are you having a fragmentation? What do I do? So yeah, I mean, this is really important, not just for people who have difficulties with their sleep, but it's also very important for people who have difficulties with their metabolic issues. Like we know, for instance, that insulin sensitivity is much higher in the morning time than it is in the evening. And so, when you're deciding if you want to do intermittent fasting, you might not know, it may not be apparent to you which time of day is the best to not eat, right? Some people say, oh, I'm going to skip dinner. Some people say,
Hmm.
I'm going to skip breakfast. And on the surface, it may appear that those are, equivalent choices. You just do what's best. And I can tell you, for me, it's much easier for me to skip breakfast and have dinner because dinner is such much more of a social event. It's where you get to sit down and review the comings and goings of the day, especially when you have kids that you barely see because they're off in high school and they're off in all these, functions.
Hmm.
Dinner is such a social environment for us, but we know medically and, pathophysiologically, biochemically, that the best meal to skip is actually dinner and not to skip breakfast because that's when you're going to get, that's when all of your genes are turned on and all of your proteins are ready to process, calories. And they're not so at dinner time. So educating them on these very simple, very maybe not intuitive, but very simple and very effective ideas about circadian rhythm can make a very big difference down the long run.
And the circadian system is it's a dual system. It's the bright days, dark nights. That's pretty much what it's all based around. Um, I'd like to start with the bright days. What does that entail? What does that mean? And what's happening with our physiology throughout, the morning, midday, and then into sunset?
Yeah, I guess before to launch into that, to sort of set the stage, and probably your audience is very well versed at this, but people who may be joining us and haven't heard this before, I love to give this analogy of Disneyland. I live here in Southern California. I don't go to Disneyland a lot, maybe once every 10 years or so, but I had a friend in high school who used to work at Disneyland, and he would tell me all sorts of things that are kind of fun. They would ride Space Mountain with the lights on, for instance. That was kind of an exciting adventure. But he used to work there at night. And the key there is that all sorts of things would happen there at night that were very specific to the park closing. So the engineers would shut down all the rides. They would check for cracks in the metal. They would check for stress fractures. The cashiers were emptied, right? The stocks in the gift shop were restocked. The gardens were weeded. The grounds were, all the gum was scraped off. So by 8 o'clock the next morning, Disneyland was a brand new park. You would walk in, every flower was in the right place. Nothing was out of place. It was like a perfect, happiest place that you could ever be. And we all know it didn't look like that at 11 o'clock the night before.
Mm-hmm.
So, you know, those types of activities that are happening allow the park to do what it needs to do during the day when the visitors come in and they're transformed into a different magical place. So our bodies are far more complex than Disneyland is, and let me suggest that it's far more magical because the complexity of what goes on in our body would make Disneyland pale in comparison. It's amazing, and the processes that occur during the day in our body, the things that allow that to happen, require a back process that happens at night. So a whole different set of genes are activated at night, a whole different set of other things, and these are multiple genes that are working in concert with each other so that if one is elevated and the other one's not there, you don't get the benefit of that. So imagine if people are lining up for, I don't know, It's a Small World, and you've got gardeners that are weeding the garden, right? Mm-hmm. That's going to detract from the experience. Imagine if you want to go on Space Mountain, you've saved up, you go to Disneyland, and that's the ride that you want to ride. One of the most famous roller coasters in the history of the world, Space Mountain. And what? The engineers have shut it down that day, right? Because and you can't ride it that day. So the question is how many of us are disrupting our circadian rhythm and our sleep at night? And what we're getting during the day is a performance that says basically, sorry, Space Mountain is shut down today. And I think that's a great analogy to use, and that's why I use it, because people start to understand that it's not just you're just laying flat with your eyes closed. Like there's totally different processes that are occurring. And when you introduce stimuli into your body that your body uses to entrain itself on that rhythm, you are in danger of messing up that rhythm. Okay, so these things we call Zeitgebers. You've probably heard that term before. A Zeitgeber is anything that is affecting or inputting into the clock. If you can imagine, you're taking a clock off the wall and you're putting your hand behind the clock and you can pop out that little arm and you can adjust the time. That's a Zeitgeber. So what are the big Zeitgebers of the human body? You alluded to that right at the beginning. That's light. Light is a huge Zeitgeber, probably one of the most powerful Zeitgebers known to man. But there's others, right? So eating food is a big Zeitgeber, especially in the peripheral clocks of the body. So we've got this master clock in our brain called the suprachiasmatic nucleus, which is supposed to entrain all of the other clocks to it. But when you eat food, that's going to set off a rhythm change in your digestive system, in the liver, in the stomach, in the pancreas, where these things are working together to digest food. And one of the big issues is that at night, there's a lot of processes that go together where there is breaking down of things, where there is repair of things, where there is processing of things, things that you could not be doing when you are awake and alert and active. Think about, remember back in the old days, 20 years ago, when you had a PC computer and you would like defrag. Like they would tell you, remember this things where you had like the defrag the computer? I don't know if you remember that stuff.
I'm probably
The
too young
hard
for
drive had
that.
all these bits of information on it,
Hmm.
and you would be defragging it so that it would all be in the same place. Otherwise, you might lose bits of information. We don't do that now, but there used to be a time when we used to do that, and you really didn't want to be opening up programs and doing other things because that would somehow affect your defragging. Well, now we've got supercomputers today where it doesn't matter. We don't even, it may even defrag on its own. I have no idea. But this is the kind of situation. So imagine at night you're defragging, and all of a sudden, what happens? You come up for a late night snack. Now your digestive tract is like, whoa, Zeitgeber, we thought we were at night. We're not. It's time to digest. Hey, you. Hey, we need these genes now to come online. And when they come online, they shut down the other genes. Okay, the ones that are doing the rest and the repair. Same thing with light, and we know this so well because we've got the pathway down. Melatonin, big antioxidant, big molecule involved with rest and repair, is secreted from the pineal gland. It's also secreted in the mitochondria of many cells, but particularly in the pineal gland, which is a little gland sort of right in the middle of the brain. It's hooked up to the suprachiasmatic nucleus, and when the pineal gland is at night, it's secreting this melatonin, which is a signal to the whole body that it's time to go to sleep. And any amount of light that goes into the eyes will hit the intrinsically photosensitive retinal ganglion cells in the inferior portion of the retina and will transmit to the suprachiasmatic nucleus, which then goes down into a sort of a circumventional pathway, but eventually up to the pineal gland and tell it to stop. So light coming into the eyes means no melatonin. What does that mean? Well, we believe that melatonin is really important for preventing cancer. In fact, there was a study that was done where they looked at people who were blind because that pathway was severed. And what they found was that those people had 30% less cancer rates than those that didn't have that pathway severed. So obviously we can't do a randomized controlled trial there. That would be unethical, obviously. Never would want to do that. But you can see in those people that have that, we see the things that we expect to see, which is a lower rate of cancer in these people who are blind. So, yeah, the question is, light. Light is the biggest Zeitgeber. Light is entraining the circadian rhythm. And when you give light to people at the wrong time, that would be the bright nights, it's going to not only delay the circadian rhythm because your brain says, oh, I'm seeing light. It must not be night, must be day. So let's push night off a little bit further. That's when it's probably coming. And so you chronically exposing your eyes to bright light at 9, 10, 11, 12 o'clock at night. It keeps pushing and further back the time for you to go to sleep so that when you do want to go to sleep at 9 or 10 o'clock, you're not ready to do that. You have insomnia. When you finally fall asleep at 1 o'clock in the morning, you still have to get up at 5 or 6 o'clock to get to work. That hasn't changed. And the amount of time that you have to sleep is being squished. And that, of course, confounds the whole issue of what's going on with circadian rhythm because now you're not getting not just good quality sleep, you're not getting good quantity sleep. So this is the big issue with light at night. And they've done a number of studies. There was a study that was, I think it was a UK Biobank study that was published in the proceeds to the National Academy of Sciences where they had people wear these watches that could detect light, okay? So this is not infrared light. We can talk about infrared light. This is visible light that we're talking about. The type of visible light that would shut down melatonin production. And what they did was really interesting. They followed these people for enough years so that a number of people in the cohort had passed away and they were able to get some endpoints to see which were the people that passed away. So what they did was they, by the hour, they had this graph where they had 24 entries on the horizontal axis going from 4 o'clock in the afternoon all the way through midnight back to 4 o'clock the next day, all across the x-axis. And then what they asked this question very simply is at 4 o'clock, in everybody's watch at 4 o'clock, they splayed everybody out and they said, who are the people that are getting the most amount of light right now? And who are the people that are getting the least amount of light right now? And what they did was they said, okay, for this hour at 4 o'clock, at the end of all of this study, when people had passed away, some of the people had passed away, who were, based on the people who had passed away, what was the effect of light on that risk factor? Was light, in other words, the people who got the most amount of light compared to the least amount of light, was that a risk factor for dying or for more likely to stay alive? And the answer was at 4 o'clock in the afternoon that light increased the chances of survival. It reduced mortality. And so they plotted it out at, they put a line of one right there where one was meant that there was no either benefit or risk, and it was actually less than one because it was a benefit. Then they did the same thing for 5 o'clock and 6 o'clock and 7 o'clock and all the way through. And what they found was this granular data. What they found was that from 4 o'clock, 5, 6, 7, 8, 9, light was a benefit. As soon as it hit about 9 o'clock, 10 o'clock, 11 o'clock, it started to approach 1, and by about 11 or 12, it flipped. Light no longer was a benefit, it now became a liability. And now light into the eyes, in other words, the people who got the most amount of light at night, 12 o'clock, midnight, 1 o'clock in the morning, 2 o'clock, so forth, was a liability, not a benefit for people. And that trend continued for 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, 5, 6. Once it hit around 6 o'clock, there was a sharp reduction. And by about 6, 7, 8 o'clock now in the morning, exposure to that bright light once again became a benefit. So we have, this is like over 80,000 people followed for years. We have data now. It's no longer like we're not sure about this. We're very sure that exposure to light is consequential. And depending on the time of day that you do the exposure, it can either go strongly in one direction or strongly in the other.
And that light is, I mean, non-native blue light is always what's demonized, but it's light of any sort, right?
Unfortunately, the sensor in those watches was not really able to distinguish between the color content of the light. It
Mm,
was just a light, just a general light detector.
yeah. So I mean, the low-hanging fruit for people is just lessen the light in your home as I mean, past that. After sunset is probably the best time to start doing that. But later in the day, right? That's the easiest fix you can do for this problem.
Yeah. And it's difficult, right? Because it's our culture and our society has really put a premium on us consuming information via screens at that hour, whether it's homework for kids, which is really diabolical,
Hmm.
or human beings that have to work because they have deadlines and they have two jobs, um, or both people in the household have a job full time, or it's entertainment, right? All of the things that you want to watch, all of the things that society says that we should watch. And this goes back, we've been sort of trained on that late night TV, entertainment, news, all of these things like prime time. I'll just tell you, when is prime time? It's 8 o'clock. 8 o'clock to 9 o'clock is prime time. And then you have late night after that and dramas and things. This is when we are been trained to consume entertainment via photons coming into our eye.
Yeah, I know it's getting worse. I'm like, a football game comes on at 8:30, I can't even watch it. It's a little better for you on the West Coast, but I
That
mean,
is true.
I feel like they keep pushing things later and later.
That is
Um,
true. Yeah.
and I wanted to hear your breakdown of the whole hormone cascade that's occurring with that morning light, the balance between cortisol and melatonin, and just how essential the balance between those two things really is.
Yeah. So again, this is the situation where we don't want things evening out. we want things to be peaked so that they can send the appropriate signal. Once the signal sort of backs off, it's not going to do the end product. Think about it this way. Think about a trumpet call, a loud trumpet call. That's something that you could hear a long distance away. It would send the signal and you would have the appropriate output, as opposed to a low murmur that may be for longer. It may even be louder if integrated over time, but it's not going to have that same effect. That's what we're talking about. And so it's not as simple as saying high cortisol, low cortisol. It has to be an appropriate wave of the cortisol. And so morning sunlight is associated with a very, very nice large peak of cortisol. And that sets up the circadian rhythm so that you're going to have a high peak of melatonin later at night and actually get better sleep. And this is the reason why people with bright light exposure in the morning time have health benefits for sleeping later that night. So a lot of these things that we talk about in terms of light is tied to circadian rhythm. Glenn Jeffrey, professor of ophthalmology at UCL, I'm sure you're familiar with him, published a study a couple of years ago, maybe 3 years ago, where he took red light, which was visible, 670 nanometers, and he was able to shine it into the eyes of people who were generally older, who had, color discrimination wasn't so good. He was able to, through a very sensitive test, actually measure that color sensitivity. And he found that people who had the 670 nanometer red light into the eyes had better visual discrimination that lasted for days after just 3 minutes of that light. Now, the interesting thing about that is that it only worked if he did this in the morning. If he did it in the afternoon or the evening, it did not have the same effect. That's quite remarkable. That means that there's something biochemically there in the morning that's not there in the afternoon. And that's quite remarkable.
And that morning light in the eyes, I know it's not much. You don't need to spend much time out there to get the benefit, correct?
Yeah, it depends so there's several different types of benefits that we're talking about. There's the
Hmm.
benefit that you might get from vitamin D. You're probably not going to get a lot of vitamin D early in the morning because the sun being low is not going to be able to transmit that shortwave ultraviolet B radiation that is required because the atmosphere is too thick. But if you're there to put light into the eyes to train the circadian rhythm, it doesn't take very long at all. If you're there to reduce the incidence of seasonal affective disorder, which is something that is going to become increasingly more common now in the next 6 months because we're headed to winter time, at least here in the Northern Hemisphere. For those that are listening in the Southern Hemisphere, you're coming out of that and you're actually getting into spring here very shortly. Having 10,000 lux into your eyes. 10,000 lux is an intensity. To give you an idea, in a regular room in your house, that's about 100 lux with the lights on. Outside in the bright sunlight is about 100,000 lux. So it's 1,000 times more bright outside. What we have found, the amount of light that is necessary to prevent seasonal affective disorder or depression is about 3,000 lux for about, sorry, 10,000 lux for about 20 minutes. Or what we would say 3,000 lux hours. So in other words, if you take the amount of lux and multiply it by the number of hours, it should add up to about 3,000. So you can imagine that if you're outside and it's a bright sunny day early in the morning, but you've got full sunlight, you should be experiencing about 100,000 lux. You're not going to need to be out there for very long for you to hit 3,000 lux hours, right? If you're out there for just a tenth of an hour, which is 6 minutes, that's 100,000 lux, right? Times zero point 0.1. You're already at 10,000 lux.
Hmm.
So you're going to hit that real fast.
Yeah, that's great. And a big a big problem for people with seasonal affective disorder is like or people up north specifically. I lived in New Hampshire for, the first 18 years of my life, and it's a real thing. You see people get depressed in the winter. It's cloudy, it's snow on the ground. Um, how essential is it still to get outside in that environment in the northern regions?
It's essential. to get outside. There's many benefits to getting outside. We know that there is good data that shows that there's benefits for getting outside in the cold. It stimulates a response in that situation. We know that fresh air has much lower carbon dioxide levels. The question is there a benefit in terms of light if the sun is not up yet? And that's difficult, right? So
Mhm.
we can talk about latitude. Obviously, the higher the latitude, the more likely it's going to be that you're going to be waking up in the wintertime and the sun isn't up yet. And so you don't have a choice about that. You've got to get to work at a certain time. The sun's not coming up, and there's those periods of months there or weeks, depending on where you are, where you're not going to get that. And so you've got to make your own sun. And that's where I would say investing in a SAD light, SAD light. You can
Mhm.
pick it up for $20 online, and just type that in. Make sure it's a 10,000 lux lamp to do that. But and by the way, there's issues with daylight savings too, right? So if
Mhm.
we were to go to daylight savings, there's certain parts of the United States where the sun really wouldn't rise until after 9 o'clock,
Yeah.
depending on where you are and where you are in the time zone. So if you're in the western part of the time zone, like if, for instance, in Barron Springs, Michigan, you're not going to be getting sunlight till 9:30. And if we were to carry daylight savings into the wintertime. So that's an issue. Yeah. So, however, if you're not limited by this, there is a whole host of reasons, but one particular important reason, which we can talk about, which has nothing to do with circadian rhythm, but it is related to the sun. And it has to do with infrared light from the sun that's coming all the time that can actually penetrate through the body, has nothing to do with the eyes, has nothing to do with circadian rhythm or chronobiology, that actually can significantly impact the functioning of the mitochondria, which has as its basis a lot of issues related to a number of diseases that decrease our longevity in this country. So heart disease, lung disease, kidney disease, the flu, SARS-CoV-2, COVID, long COVID. All of these things are related to our ability to deal with them, and that is rooted in the mitochondria. And there is new evidence that's coming out all the time now, and number of papers that have just been recently published that show that there's other reasons to get outside in the sun other than just vitamin D
Mhm.
and chronobiology.
And that's where a lot of people get stuck at the level of vitamin D. And it's really, I've heard a lot of people, I mean, it's essential, but it's a biomarker essentially for the time spent outdoors. Um, and our modern lifestyle is driving an infrared deficiency. It seems like more people are inside, they're not collecting that free energy, honestly, charging up their mitochondria. And you speak about infrared light very eloquently. So I'd love to hear your breakdown of just how essential it is and what it's exactly doing to our mitochondria.
Yeah, so there was a paper that was published. It was a randomized controlled trial in the prestigious journal Nature Scientific Reports. Glenn Jeffrey, again, UCL, very elegant study. He took a number of subjects outside into the sun and was literally able to measure sunlight coming through the other side of their body
Hmm.
using very sophisticated and sensitive detectors. Obviously, it was much less than what was going in, but it showed that infrared light, which is that type of light just beyond the red spectrum that you cannot see, but you can feel it as warmth, is able to penetrate through and affect changes in the human body. So, how was he able to show that it was affecting changes? He was able to show that when he brought these subjects inside and then in a very controlled setting, applied that wavelength of light, which was 850 nanometers, which is the one that seemed to go through the best. When he applied it to people in a randomized fashion, he was able to show that the mitochondria in the retina were upregulating their energy output, and this was allowing people to see better. Now, this happened, interestingly, whether or not he covered their face with a barrier or not. And that tells us a number of things. It tells us that you don't have to have the portion of the body that wants to get the benefit in the path of the light. And we kind of know this. It's from an aposcopal effect where the mitochondria that are affected in the wave of the sun, in the path of the sun, can communicate this information to other mitochondria that are not just in the organ itself, but actually distant organs in the human body. We actually have data on that from independent groups. So this one paper, I think, really kind of blew it open, but it explains a lot of the data that we've seen up to that point in time. There's a study that was done showing that people who eat glucose load, everybody's glucose is going to go up. Those people that had light on them in the experiment in a randomized fashion had lower peaks of glucose, meaning that there was a systemic effect of infrared light coming from the sun that had an effect on the human body. The principles of this is that, number one, infrared light can penetrate very deeply and essentially go through the human body, affecting all of the cells along the way. That's number one. Number two, it can also penetrate through your clothes. So the feeling the need to, not have clothes to get the benefit of this type of light is not necessary. If it can go through your body, it can go through clothes. If it can go through clothes, it can go through sunscreen.
Mm-hmm.
If it can go through sunscreen, it can go through a broad-rimmed hat. I mean, you may choose to either wear this stuff or not wear this stuff for other reasons, but from an infrared standpoint, this stuff has no problem penetrating through these potential barriers. The other aspect of it that is really important and something that's really fascinated me recently, and I'm actually looking at this really attentively, is the ability of leaves and grass and greenery to highly reflect infrared light coming from the sun to our direction. Such so is that if you're in a green environment, you're actually getting multiples of infrared light to your body if you are in and around that type of environment. So we have seen multiple studies prior to these recent ones that I just described that have shown that people who are exposed to light have less total mortality, less cardiovascular mortality, less cancer mortality, better longevity in multiple different arenas. There was a Swedish study, for instance, that was published in 2016. Women who had the most exposure to sunlight had the least mortality, total, cardiovascular, cancer, and non-cancer. Repeated again, UK Biobank study, Richard Weller, 300, 400,000 people published last year. It showed that solarium use and shortwave radiation in the UK was associated with a reduction in all-cause mortality, essentially repeating all of the study outcomes that were seen in the Swedish study. But interestingly, no statistical increased risk of incidence of melanoma and a statistically significant reduction in all-cause mortality or cancer mortality that was not skin cancer related. So there's that. There's other studies. There's Oxford study that looked at people drawing their blood at different times of the year and then looking back 7 days and showing that as the amount of sunlight increased by the hour, the triglycerides in those individuals and the triglycerides reduced and the insulin sensitivity increased in those individuals as the weather report for that day changed. Numerous studies involving not just that, but also influenza. Harvard study, Harvard Kennedy School, looked at a number of years of the flu pandemic, not just in the United States, but specifically also in New York. And what did they show? When they looked at all of the data, they could see a very, very strong correlation between sunlight and influenza that led them to conclude that sunlight was actually very strongly protective against getting influenza. We could go to COVID, the same sort of thing. So we see a lot of these epidemiological signals. I mean, these studies are not designed to show causation. Mm-hmm. To be able to show causation, you need to have a randomized placebo-controlled trial. And getting back to my thing here, and I'll just finish this up here with my experience as a critical care physician and dealing with COVID, the two things that really set me off in terms of COVID when I was looking at my patients was that the ones that did better were the ones that had normal or elevated vitamin D levels, as we talked about. The ones that did worse had lower vitamin D levels, and yet when we tried to supplement with them, they didn't always get better. And this may be a result of metabolism or the type of vitamin D we're giving them. But the other aspect of this that really struck me was the ACE2 receptor, which the SARS-CoV-2 binds to. ACE2 is a very important enzyme in the modulation of oxidative stress in the cell, and that has a lot to do with the mitochondria. If your mitochondria is not working, it's likely related to oxidative stress. And we have very good data that people who are infected with SARS-CoV-2 have worse oxidative stress. And so I began to think, is it possible that perhaps sunlight was causing something else that vitamin D was simply a biomarker of, as you suggested?
Mm.
And maybe the thing that it was doing was it was penetrating through the body, causing melatonin to be produced. And that melatonin is a very powerful antioxidant, and it was mitigating the major damage pathway of SARS-CoV-2. So I was very happy to see in 2022 a paper that was published in Brazil where they set out to do a randomized placebo-controlled trial where you could actually show causation. And what they did was something very interesting. They took people that were sick enough to be admitted to the hospital with COVID-19, not sick enough to be in the ICU, and they randomized them to wearing a jacket with LEDs on the inside that gave light forth at 940 nanometers, which is smack dab right in the infrared spectrum where we should see this kind of benefit. And they switched on the jackets in a random fashion in these patients for just 15 minutes a day, once a day. And they did it for 7 days. And at the end of this, they unblinded it and they looked to see what happened. And in every single endpoint in that study, there was a statistically significant difference between these two groups. The people with the LED jacket that were getting infrared light had better saturations faster. They also could breathe more deeply. They could breathe faster. They could breathe with more force. Their heart rates improve faster. Their respiratory rates improve faster. The lymphocytes in their bodies, which are responsible for getting rid of the virus, not decreased like it did in the control group, but actually increased. And here's the biggest endpoint. The average length of stay in the control group was 12 days. Those people that had the jacket switched on for just 15 minutes a day went from 12 days to 8 days. They shaved 4 days off
Wow.
of their hospital admission, which is huge when you consider the costs of dealing with that type of hospitalization. So when I saw that, it was clear to me that this is exactly what we needed to be doing. And that's when I started to make the change in my own practice about getting COVID patients and maybe even patients who are sick in general outside into the sunlight just 15 minutes a day. These are hospitalized patients to get them outside. And there are people all around the country that are starting to do this. They're starting to look into this. So I believe that we're starting a new type of practice here. But you know what? It's not new.
Yeah.
If you look back 100 years ago, this is what we were doing because we knew that it worked. And so it brings up a whole host of other questions like why, how did we get here?
Hmm.
Why did we forget this? And that's a more of a philosophical topic. But regardless, I think I've come full circle, and really this has been kind of my mission in terms of this is to raise awareness of the benefits of sunlight. We're not talking about getting out, for hours and hours and hours and get sunburned. We're talking about literally 15 minutes of light from this jacket. And I believe the intensity, by the way, was like 2.9 milliwatts per square centimeter. It's not huge. It's not huge.
So it seems like, you have all these organs that have such high energy demands, and the modern lifestyle is set up to just create oxidative stress, and where there's a lack of mitigating that oxidative stress with that cellular melatonin. And I understand you need placebo-controlled trials, it's essential, but with something like infrared light, it seems like the answer is pretty simple. And obviously we need to see more, but you can get outside, you can fully cover your body and still experience all these benefits. Do you think
Yeah.
that this is something that it's catching on clearly? Have you seen other or talked to other physicians, and are they implementing a lot of this stuff? And just is it catching on too slowly is kind of where I'm getting with this question.
I want it to catch on right now. So yes, it's catching
Yeah.
on too slowly. But you know what? There's a lot of inertia in the practice of medicine. What I mean to say is people don't change practices unless they are forced to,
Hmm.
because it's just human nature, right? We don't change our practices when things are working, or at least we think that they're working. I will say though that I am pleasantly surprised that one of the hospitals that I'm working at, there are people who have joined this team and are very excited about doing these things, and they see that it makes a lot of sense. In fact, may I even say that there's some talk about taking out one of the ICU rooms to make a door so they can go outside through that area into a nice little area that they can make so that we can get these patients outside. So we are making progress. I really do think that the first hospital to really integrate heliotherapy
Hmm.
into their inpatients and show it, demonstrate it, and do a study on it. And I know it's going to work because we have studies already that does this. And show not only that, but also the impact of length of stay. You know, a lot of people don't understand the financial aspect of medicine. I was lucky enough to be on a board of a $250 million medical management company. And so I saw how things work. I live in Southern California, and in Southern California, we are very mature in terms of capitation. What is capitation? And I just bring this up to show you that the reason why these things are not catching on in the hospital is not because it doesn't make financial sense. It does. It's just they're not seeing it. And I'll explain why. Many arrangements in the hospital, how a hospital makes money is when a patient is admitted to the hospital, the physician who cannot be employed by the hospital, he's an independent agent in the hospital. He only has privileges to work there. He doesn't get paid by the hospital. It's the physician who makes the diagnosis. And when the physician makes the diagnosis, if it's pneumonia, if it's congestive heart failure, whatever these things are, the hospital then goes to the insurance company of this patient and say, hey, look, this physician diagnosed this patient with this diagnosis. And the hospital already has a contract with the insurance company that if a patient comes in with this diagnosis, this is how much the insurance company is going to give the hospital, period. So if it's a pneumonia, that's the amount of money. So now it's incumbent on the hospital to do everything it can in its power to get that patient as well and as fast as possible so that it doesn't use up resources that erodes at that payment that it gets from the insurance company. Do you understand what I'm saying?
Yeah.
It's called a DRG. It's also known as subcapitation. If you want to look this stuff up, you can see. And so really what the hospital is doing here, or what they should be incentivized to do in this kind of a situation, is to get patients better, faster, and out of the hospital. Okay? So you could see how sunlight in that type of an environment would be amazing. It would
Hmm.
almost be cheating, right? Because you're taking, like, these things are well thought out, well negotiated. If they know that the average length of stay for a COVID patient is 12 days, then they're going to work into the equation to get paid for 12, maybe 13 days, right? They have to make some sort of profit on it, right?
Hmm.
They got to pay their employees, but they probably have to put money into the foundation so they have money in case for a rainy day. Imagine now they're getting paid for 13 days, right? But it's only costing them 8 days to take care of these patients. And how much does it cost to get somebody out into the sunlight? It's nothing, right? I mean, the
Hmm.
sun is there. If you're in Southern California, you've got what, 300 days of sunlight.
Yeah.
So, people will say, oh, the reason why that we're not instituting sunlight is because, it doesn't pay or it doesn't. There is a mental block for some people, and there is an inertia of making things happen. I'll tell you where the real block is, where I've come in practically. Here you have these poor nurses who have ratios. They have to take care of 3 patients or 4 patients or 2 patients if the ICU. And it's very difficult for them to leave their other 2 or 3 patients and watch this patient as they take them outside, even for 15 or 20 minutes, and then have to bring them back. They need somebody to watch their patients because there's a liability there. If
Hmm.
something goes bad and no one's there to catch it and something happens, then it's on the nurse and it's her license and it's the hospital. So what I've proposed to get people outside is the development of a separate outside unit with a charge nurse and nurses that are continually throughout the day accepting patients for 20 minutes and sending them back, and then getting another set of 20 minute for patients and then sending them back. I think that would eliminate a lot of the issue and get patients outside. Look, it's not rocket science. It's
Hmm.
not like it's a new medicine that has to be FDA approved. What are the side effects of getting somebody out in the sun for 20 minutes? I don't think we're going to be seeing sunburns.
Hmm.
I don't think we're going to be seeing, crazy adverse events. That could probably be studied in a pilot project. But I think this is a really easy, cheap, reachable endpoint for just about any hospital to be able to do in some way to improve the patients. And if the patients are too unstable to move, we could develop something like they did in this Brazilian study where they have a jacket that they could put on,
Hmm.
flip it on for 15 minutes, take it off, find a way to sterilize it or pull something off so you could put something else on and not, obviously you don't want to transmit infections from patient to patient, but there's ways of doing it. And I think if this is true, if this randomized controlled trial rings true, and obviously I'd love to see it repeated again. This was on 30 subjects.
Hmm.
There are some major developments that we could do and improve of life in our society.
And do you think, as you alluded to before, we've kind of come full circle on this issue? Like, uh, you reference Florence Nightingale all the time. They recognized way back in the 30s and before that putting someone in the sun or even near a window can have huge benefits to a patient. What do you think has caused the loss of this knowledge? Is it just reducing to single body parts? What do you think it is?
No, so it's interesting. If you look back at what the state of the art was in the 1920s,
Hmm.
let's go to probably the biggest hospital, the one that all of the presidents would go to if they wanted to get well back in the 1900s, 1910s, 1920s. It was the Battle Creek Sanitarium set up by John Harvey Kellogg. Amelia Earhart, Warren G. Harding, Roosevelt, Ford, Rockefeller, all of these guys were visiting and had gone to the Battle Creek Sanitarium. And what were they doing at that time? This is before antibiotics. This is before a lot of there were medications, but it wasn't as much as we see today. What were they doing in that facility? They were doing heliotherapy. They were doing sun treatments. They were doing exercise. They were doing hydrotherapy. Now, granted, these were not these people that were checking into this facility, the Battle Creek Sanitarium in Battle Creek, Michigan. These were not the same type of patients that are now being admitted to the hospital. The type of patients that are being admitted to the hospital now are far sicker than the type of patients that would check into the hospital 100 years ago. Okay. It's because of a lot of the science that we have today that we're able to keep people alive longer. And
Hmm.
so when they do become sick, they are sick. Okay. So these were not as sick people, but what was the treatments that were happening? This was the state of the art. This is where it was the largest hospital in the world, Battle Creek, Michigan. And this is where they had people that would go and they would get better. Okay. They knew what the issues were and they knew how to, like, people would not exercise. People would not be going out into the sun. People were not getting the benefits of all of these 8 simple laws of health. So this is the 1920s. Okay. In fact, just to put a cherry on the top of that, there was a Austrian psychiatrist by the name of Wagner Joreg who saw in his patients in Austria, his neurosyphilis patients, that they got better when they had a fever. So he decided to do artificial fevers and he was able to cure the neurosyphilis. He did that actually by injecting them with people with malaria. Their blood had
Hmm.
malaria in it, which is crazy. Had high fevers. The high fevers cured them of neurosyphilis. And then, of course, they had the treatment for malaria at the time with quinine. They could not cure neurosyphilis. Why? Penicillin had not been discovered. And so Wagner Joreg gets the Nobel Prize in Medicine in 1927. Okay, this is where we are. Sunlight, hydrotherapy, artificial fevers, all of these things. This is 1927. What happens in 1928? The discovery of penicillin. And now we go down a path where instead of taking along with us all that we had learned before about sunlight and hydrotherapy and all of these natural practices, We now dump that and we think that we're making progress and we go down a path of randomized placebo-controlled trials on drugs to making sure that they are safe and adequate. And look, I don't want to in any way denigrate the benefits of some of these medications and drugs. I use them in the intensive care unit.
Hmm.
I have patients that are near death and I pull them out of the jaws of death because I'm able to use medicines quickly. I don't leave it there. Obviously, I don't leave it there. I set them on the right path by talking about how they got into that situation in the first place.
Hmm.
But what happened was the architecture of hospitals started to change. And I can actually show this. I actually have the articles in the architectural societies where there was a shift away from sunlight, fresh air, windows in patients' rooms, all of the Florence Nightingale attributes towards the ease of making it less labor intensive for nurses to pass medications to patients. I'm not blaming this on nurses. This is the architecture of this. And so instead of these sprawling units with large rooms and ceiling to floor windows, we had smaller rooms that were able to be reached more easily, more effectively. And I remember this. There was a paper. This was back in the 1930s, 40s, and the big scandal is that the new architectural designs had patient rooms without windows. That was a scandal.
Hmm.
And it had passed. People started to build these buildings, and then we just completely lost sight of it. We saw it as old and antiquated, and that we had new treatments that we didn't need to use these things that actually were very effective, like penicillin, streptomycin for tuberculosis, things of that nature. Here's the problem, though, and this is a philosophical issue that I have with it, is that in 1919 was the last major pandemic that we had in this country before, obviously, COVID in 2020. And we did not have medications. We did not have vaccines. We didn't even know really what that was. It wasn't until after we discovered it was a virus that caused that pandemic. The issue now that we have is that we have fully bought in to the supply chain dependent pharmaceutical route to treating pandemics. And that's what we bought into.
Hmm.
Before, we didn't have any pharmaceuticals, and all we had was sunlight and hydrotherapy and all these things which are not dependent in any way on a supply chain. You can pretty much go outside. You can pretty much get sunlight just about any time if you really try. You can get hot boiling water that you can help you with hydrotherapy and
Hmm.
bringing up the temperature just about anywhere. Now what we've done is we've forgotten all of those things. And now what we have are very supply chain dependent interventions. And here is the weak point of that. Here is the Achilles heel of that. If we were to have a pandemic that was so severe that where we had 20 to 30% mortality, like the last pandemic had less than 1% mortality.
Hmm.
Okay. And we saw the supply chain challenges in that. We still even have supply chain challenges today. If we were to have 20, 30%, barring the fact that AI completely doesn't take over and we don't have humans doing these transportation jobs, we are not going to have a supply chain. And so all of the research that we've put into a medication or a drug or a vaccine, God bless them to do that, right? But if we can't get it to the end user, if a tree falls in a forest and there's no one around to hear it, does it make a
Hmm.
sound? If we put all of these millions of billions of dollars into a medication to be ready for the next pandemic, and it's supply chain dependent, and we don't have a supply chain, and we've doubled down on that method alone. I'm not saying we shouldn't invest. I'm saying
Hmm.
we've just doubled down on that alone without bringing back an understanding about other things, of complementary things that can be done at the same time. Then I think we're in a worse situation that we could be in.
So essentially, it seems like all our eggs are kind of in one basket, and we've used medications as a crutch a little bit to get us to this point.
Yeah.
And we have something like COVID-19 where we're so sick as a society that it has a big negative effect. Um, so where do we go from here? We pretty much have to, from based on what you're saying, how I'm interpreting it is we have to kind of meet in the middle, right? Like use these medications when needed, but don't rely on them.
Yeah, so the way this is my philosophy on this. Imagine your body, your life is like a link, a chain of links. Okay, each one of those links is an organ system.
Hmm.
Your heart, your lungs, your kidneys, etc. We know that as we go through life, especially if we violate the laws of health, those links are going to be eroded at different speeds.
Hmm.
And one of the most common scenarios in the United States is that that cardiovascular link is the one that's eroded most often. And so what we see is medications being used in these situations. Now look, here's a truism that you can take to the bank. Every medical intervention, especially medications, have side effects. And so what we're doing in these types of patients is we are recognizing that the cardiovascular link is ready to break,
Hmm.
but the other links are not. And so, what is wise to do in that situation is to use a medication that will leverage the strong links to protect the weak links. In other words, medicines that have side effects that affect the stronger links, but protect the weakest link, and so that it doesn't break. And you will see very clearly and not surprisingly that when those medications are used in those situations, it can extend life. And but don't have this idea that medications somehow intrinsically extend life. What would extend life even further is to figure out what caused that link to become weak in the first place. And that's where I get to the 8 laws of health. So, nutrition, exercise, water, sunlight, temperance, that means reducing toxins like alcohol and tobacco, fresh air, rest, not only a daily rest, but a weekly rest, and trust in a higher power. Almost all of the diseases that we face today are a result of the violation of one of those 8 laws. And so, what I would advocate is yes, you come across somebody who comes to you either in the hospital or in the clinic, and you see that their link is weak, and you are almost forced to in that situation to prevent them from dying or from getting worse, is to institute these medications to leverage the good links so that you can strengthen the weak links. But, but institute New Start, which is a mnemonic for those 8 laws of health: nutrition, exercise, water, all the way through.
Hmm.
Actually, it's been used quite often and actually is used and has been sort of branded by a university just outside of Sacramento called Weimar University, who uses it. Introduce New Start into their lives, because here's the idea with New Start. Whereas medications have side effects, the principles of New Start have side benefits. Okay,
Hmm.
so I would institute exercise in somebody who has cardiovascular disease, but exercise is not only going to improve their cardiovascular link, it's also going to benefit their depression. It's also going to benefit well-being. So these principles, they don't, as opposed to medicines which strengthen one link but weaken the other in the process. The institution of these New Start principles strengthen all of the links. And if we could start to do that and use medications when we have to. Look, like nobody anticipates that they're going to get into a car accident. Nobody anticipates that they're going to be in a trauma center or have to go to emergency
Hmm.
surgery. But it happens, right? And if it does, please use general anesthesia. It's a big pharma product, but please, if I ever get in that situation, use general anesthesia. I
Hmm.
want that. I don't see that as an evil. I don't want to go back to the pre-Civil War days where you kind of get a knock on the head and some ether. I mean, there are some benefits to these medications, right? But the problem that we have today is that people have demonized both of these sides. And really what we need to do is take a more holistic and moderated and sensible approach to what it is that we're doing. We want to make all of the links stronger. Sometimes we're forced to use something that's not ideal to protect one link because of the situation, but ultimately the best solution is to use a non-pharmacological, very easily adapted New Start solution that strengthens all of those links.
That's a great breakdown, and I think it's absolutely essential. And I think just from my own experience with family members, you're obviously an exception, but it seems like when someone needs life-saving care, they do everything they can. They save their life. but then you go to rehab for 2 weeks and you're off on your
Yep.
own.
Yep.
Um, how critical is that outpatient care, and what do you think doctors need to do better than they're doing currently?
So I'm in a unique situation because I'm a pulmonologist, and that typically is in a clinic where I am, and I see people who walk in. So they're clearly not at the end of life. They're able to walk in on their own usually.
Hmm.
And then on other days, I'm working in the intensive care unit, which is at the other extreme. So I'm seeing stuff that happens at the beginning. I'm seeing stuff that happens at the end. And so I see it. I see it both places. And yeah, we need to do a better job of using lifestyle medicine to prevent things from happening in our patients. Now, that's not to say that it's not happening, because as I sort of set up before, what what is the incentive in some of these medical schemes where you have the medical group being paid for by the insurance company? And again, this is almost the majority of the situation where I work in Southern California, and it's spreading. It's becoming more and more popular. I would say that more than 50% of the people in the United States are under such a situation, either HMO or Medicare Advantage, where the people pay their premiums to an insurance company, and then the insurance company pays a fixed amount. In other words, there's no risk to the insurance company. They pay a fixed amount to the medical group to say, this is how much we're going to cover you to cover the health care of these many people in your area. And if they get sicker or they need more help or something happens to them and they need more work or they need a surgery or they have to go to the hospital, you have to pay for it.
Hmm.
Okay. So the medical group is now incentivized to do everything in their power that they can do to prevent things from happening. You know the expression, right? An ounce of prevention is worth a pound of cure, right?
Hmm.
So it's much more financially feasible for a medical group to pay for things that prevent disease, because if they allow those things to go to disease, it's going to cost a lot more money. Let me give you an example. Sleep apnea. It costs them over $1,000 to get them set up with a CPAP machine. But we have great data that shows that CPAP machines, when they're worn and they're compliant with it, will prevent strokes, it will prevent heart disease, it'll prevent heart attacks, all sorts of things. Because one CPAP machine that costs $1,000 that is used for 5 years is far cheaper than it costs for somebody to have a stroke and go into the hospital, where it costs thousands of dollars on a daily basis to take care of that patient. You see what
Hmm.
I'm saying?
Hmm.
So again, the medical groups, the doctors who are part of the medical groups, are actually incentivized in many of the programs that we have today to really focus on preventative care. The problem is that I don't know if they're equipped to be able to have that discussion. I don't know if they have the time to really have that discussion. And I want to be honest with you. I have that discussion with my patients, but here's the barrier that I run into in terms of patients' expectations. Like if somebody comes to me and they have these issues and I talk to them about what we've been talking about today, oftentimes they don't feel like they have gotten what they came to a physician for because they haven't gotten a prescription.
Hmm.
Or they may feel like I have minimized their concern by just telling them to get out into the sun, not understanding how beneficial sunlight is. Do you understand what I'm saying?
Absolutely.
So this is the interaction that we're having in the clinic, and sometimes they will just not feel satisfied unless you have given them a prescription. And this is a problem that has been built into the system for many years. There's this expectation that people have that if they're sick, they need a pill. And if you want to get away from that, you have to expect that you're going to disappoint some patients. And that's just you just have to expect that, but realize that that's what's going to happen.
How much do you think the dermatology profession has influenced this kind of negative mindset around the sun, and leading patients to feel like that's not an accurate preventative or boost to their health?
Yeah, I can't blame the dermatologist too much because, I mean, honestly, they are at the end of one of the lines of the assembly line, right?
Hmm.
Anybody who ever gets a problem with their skin goes to the dermatologist. So if you think about it, all the dermatologist sees all day is skin damage and skin disease and melanomas, and so it's very easy to see in their mind how this is such a prevalent problem, and it's related to the sun because the sun has ultraviolet light in it.
Hmm.
I do believe, though, that there are forward-thinking dermatologists. One that comes to mind is Richard Weller. He's out of the University of Edinburgh, Scottish university, that's published a number of papers. It was sort of the force behind that biobank study that I talked about with solariums and
Hmm.
shortwave radiation. He actually published a review recently in the Journal of Investigative Dermatology, and his article was titled "Sunlight: Time for a Rethink," where he goes through all of this data. And credit to him, he lays it out there, and it's for his colleagues. And I believe we're moving the needle because there's a
Hmm.
number of dermatological societies that are now, they're now acknowledging, even in Australia, of all places, where they have the worst
Hmm.
amounts of, ultraviolet light and skin cancer, that there are benefits to sunlight, and we need to have a rational discussion where we're not demonizing the sun, calling it a deadly laser. There has to be a balance, and what is that balance? And I think that really depends on skin color, location, time of year, all of those
Hmm.
sorts of things.
Yeah, and I wanted to jump into like the benefits of UV light because it's demonized so much.
Yeah.
Uh, how important is UV light for our physiology?
Well, we are just learning about it. The problem is that we discovered vitamin D and we thought, well, that's the only purpose it has, right?
Hmm.
And even today, people think, oh, I'm going to go outside and get my vitamin D.
Yeah.
Well, we now know that you're actually going to get a lot more than just vitamin D. Certainly, vitamin D is important. There's a number of randomized controlled trials that show improvement in autoimmune disease. It shows improvement in acute lung diseases, respiratory diseases. It's important. I think, ultraviolet light is there to disinfect. It has signaling markers. I do believe it's important. I do believe that it is important to get. Um, but just like anything else in medicine, right? You can drink too much water,
Hmm.
but water is essential for you. You can have too much of anything. Food is essential for you to live. Is it possible for you to have too much food? Absolutely. So you will never find a an item or a material that the body needs that you cannot overdose on. So finding something that you get too much of should not be surprising because that can happen. And is it possible to get too much sunlight? Absolutely, especially if you're not accustomed to
Hmm.
getting too much sunlight. If you've been on a long fast and all of a sudden you've taken a bunch of food, that's going to cause refeeding syndrome. If you've been going along and you haven't drank water and you drink too much water too quickly, it can cause brain swelling in an extreme situation. So I do believe that ultraviolet light is beneficial. We know that it is. I believe it has benefits outside of vitamin D. We know that from a number of studies in terms of hormones and things of that nature. So yeah, it's beneficial, and but you can get too much of sunlight. It's possible.
Hmm.
But what we've been talking about today is nowhere near that amount.
Yeah. So what's your like safe practice for UV light personally?
I don't, you're asking the wrong guy because I don't get a lot of problems with skin issue. I mean,
Hmm.
my father is from the Caribbean, and his grandfather was from India, so I've
Hmm.
got that type of skin type. My mother, on the other hand, is from England, and she's, as white as the wind-driven snow. So I'm sort of a nice
Hmm.
combination. But I have cousins on my mom's side who are white as snow, and they could be as red as a beet. We took them once to Las Vegas and they were outside in the sun for too long. They were red as a beet. They were not
Hmm.
ready for that. They're from England. So, you know, I think there's an adaptation that has to be made. It has to be done, smartly.
Hmm.
And depending on the skin type and where you are and how much and the UV index, you've got to be smart about it. You shouldn't overdose on it. If this is something that people are listening to right now, that they haven't gotten a lot of sunlight, but they're interested in doing it because they believe that it could help, I would jump into it slowly. I would slowly build up. I would get outside, especially in the morning and in the evening. That's when there's the least amount of ultraviolet light. That's the high energy photons that can bend and break double bonds. But don't shy away from it. Like get
Hmm.
outside and get out into the light. And if you're out there for 10, 15, 20 minutes, I would be very surprised if there's deleterious effects.
Yeah, I think we've just simply moved the needle too far in one direction, and it's obviously you don't go out and just burn yourself to a crisp. You gotta
Right.
meet somewhere in the middle. It seems like that's pretty much where everything in this conversation is rounding back to.
It is. Moderation.
Exactly.
And that's a
Okay.
call to go out into the sun because right now we're spending 93% of our lives inside either a house or a car, and that's just not enough. I mean, the 7% that's left is just not enough.
Exactly. So it's just honestly, and like we said before, it's just small amounts can go a really long way in our biology. The one
Yep.
thing I wanted to circle back on with in terms of greenery was the study out of Louisville, Kentucky.
Oh yeah.
That was pretty amazing, and I just love hearing you talk about it. So, what was going on in that study?
Yeah, so as I talked about at the beginning, one of the things that is just so amazing to me, and I'll have to tell you, you'll have to get it. Or maybe I'll send you a link to it. There's a little film that you can get. Actually, I have it right here. Hold on a second. It's this little film. I have no connection with this company, but Phosphortech
Hmm.
makes this little film, and you can put it over your iPhone camera. You just put it over it, and what it does is it's really interesting. It takes the longer wave infrared light and it bumps it up into the visible spectrum, so you can see it as red light. So you
Mm.
put this over your camera, and you go outside, and what is amazing is the leaves on the trees and the grass just like spike.
Hmm.
You never realized that you were getting that much infrared light just by walking out into a green space. And this is the reason why I'm convinced that for decades we've seen an improvement in diabetes, in total mortality, in cardiovascular mortality, in people who live in green spaces. I've been convinced of this, but whenever I talk about it, people, the naysayers say, well, it's because people who live in green spaces have more money, they're able to get better care, they're walking, they're exercising. This is the reason why we're seeing an improvement with people who are living in green spaces. So, how are you going to argue with that? It's hard to do a randomized controlled trial
Hmm.
in that way to actually establish causation. But these guys, man, this is called the Green Heart Project, and this is what they did. They went to an urban sprawl in South Louisville, Kentucky. It's about 4 square miles, and it was just basically you can imagine an urban sprawl, just nothing but buildings and
Hmm.
concrete and roads. And somehow they were able to plant 8,000 trees, not little saplings that you pick up at Home Depot. These were fully mature trees with leaves on them, and they planted 8,000 of them in 4 square miles. That's like 2,000 trees on average per square mile. That's a lot of trees. Now, before they did that, they randomized and they took 745 people from that area and they measured something called highly sensitive CRP. This is a surrogate marker for inflammation that's been tied to in the past to strokes, heart attacks, and that sort of thing. So they measured on everybody. Then they went over the next 2 to 3 years, planted these 8,000 trees. Did not institute, any kind of income project. They didn't give them an exercise program to do. They just left them as they were. The only thing that they changed was just literally putting a hole in the ground and putting a tree in it and then covering it up and watering it for 2 to 3 years. After that, they went back, they measured everybody's HSCRP levels. What they found astounded them. It dropped by, on average, anywhere between 13 to 20%.
Wow.
Now, when they looked at that, that translated to a reduction in stroke by 15% in that area. That's huge.
Hmm.
And all they did was plant trees. And if you were to take this little thing, it's called an IR sense. If you want to pick it up, again, I have no financial connection with the company. It's Phosphortech. You can see it on the internet. It's $30. You put it
Hmm.
over your camera, walk out where you are. There's a number of things that you'll see in your environment. First of all, you'll see that there is so much more infrared light outside. Okay. The next thing you'll do is when you walk inside and you put it up to your lights, you'll see that incandescent bulbs have this red hue about it because that's the infrared light that's coming off,
Hmm.
whereas LED bulbs do not. And by the way, in 2028, the rules for LED bulbs are going to get worse, not better. And they're going to become even more restrictive. So watch for that. The other thing that you'll notice is that when you open a window and you look with the iPhone or your smartphone through the window, you'll see that there's far more infrared light coming through the screen than there is through the window itself. So what has this all told me? It tells me that if I want to get enough of the beneficial infrared light, especially if you're working at work during the day and you can't get outside, they've put LED lights. You can choose if you want to have LED lights at home or if you want to try to scrounge around and find incandescent. You
Hmm.
don't have that option at work. The office buildings that we work in have to be permitted, and the permitting is very clear. They have to have certain energy requirements. They have to have certain glass. So what we are doing is we are working in an environment that is completely bereft of infrared light. And many times we are going home after the sun goes down, which is the major source of infrared light, and we're getting there in the morning well before the sun comes up. And so you could go for days, weeks perhaps, without exposure to much infrared light. So what has that told me? That has told me that whether it's cloudy outside, whether it's rainy outside, you're still going to get more infrared light by walking outside, not sitting in front of a window, not turning on a light, walking outside of your dwelling so that you can get the beneficial infrared light that your body actually needs.
That's really amazing, and it's such a simple fix for a lot of people. Um, and I mean, your mitochondria are gonna thrive. I feel the difference when I'm outside, whether it's rain or shine. It really you can feel it. You even if you're not feeling the heat of the infrared, you feel much better just taking a step outside. And it's a problem in hospitals as well. I mean, the infrared uh, content in there is zero,
Right.
and the lighting is awful. It's not exactly conducive for healing.
Yeah. I mean, Bob Fosbury, who is an astrophysicist at UCL, has said that the lack of infrared light in the 21st century is the scurvy of the 21st century.
Hmm. It's truly remarkable. And the last thing I wanted to touch on was like where do hospitals go? I know you want to implement spaces just where they can get outside, but I mean adding like a simple a garden or
Yeah.
a space where people can sit where they're recovering. Um, do you foresee that in the future of hospital architecture?
I hope so. In fact, there is a group of architects in Europe that are meeting with some individuals that I'm aware of that want to take this new information that they're gathering and they want to incorporate it into their architectural hospitals. I haven't heard what the outcome of that is,
Hmm.
but I will be actually speaking for something called the Guy Foundation, GUY. It's going to be in November, and it's a whole lecture series that's in England. I'll be speaking remotely. If people wanted to tune in or to search that on the internet, and all of those talks are going to be based on these types of talks where we're talking about light and the benefits of light and the interaction of humans and architecture in light.
That's amazing. I'll definitely tune into that. Thank you so much for coming on. This has been enlightening.
No pun.
Where can people find you if they want to reach you? Yeah, exactly. Where can people find you on social media?
So we still have our YouTube channel, MedCram, MEDCRAM. MedCram, that's the YouTube channel. We also have our website that is geared for people who want to get a little bit more in depth in the medicine or even want continuing medical education. That's medcram.com. I'm, of course, always on X. I post frequently,
Mhm.
and you can see me there as at Roger Schwelt, just my last name, MD.
Amazing. Thank you. And I'm sure we'll do this again. There's plenty of new research coming out every week. So I really appreciate you taking the time to come on.
Hey, thanks for having me on, and till we meet again.
Thank you.